So the topic of my talk is my efforts to clarify the mechanisms of ketamine and thinking about how these mechanisms might pertain to addiction treatment, but also more broadly for the other psychiatric disorders that ketamine has shown efficacy for. So as Rupert said, I've received funding from NIDA. I've also received funding from NIAAA, which is the division of NIH here in the States focused on alcohol use disorders. I've also received funding from the Research Foundation for Mental Hygiene here in New York City. None of the research has been funded by industry or foundations. There are no conflicts of interest to report. So this is ketamine, and I don't need to go into its history too much. All of you know that it's dissociative anesthetic, PCP like compound, binds to the same receptors as PCP does, and has some unique capacities as an anesthetic. It doesn't affect respiratory functioning much. It's sympathomimetic for those who might be hypotensive. And at subanesthetic doses, it has an array of psychoactive and therapeutic effects. The psychoactive effects lending themselves historically to recreational use, and the therapeutic effects ranging from analgesic to antidepressant to anxiolytic to potentially anti-addiction effects. Often seen immediately after a subanesthetic dose is received. So a very interesting compound, and again, I don't need to go into the history of it much, but a compound that I was drawn to when I started my research career for simple reason. I was interested in compounds that simulate the meditative experience. I entered into doing research very interested in how we might employ meditation practices, integrate them into behavioral frameworks so as to disrupt addiction. And providing meditation-based frameworks to individuals was helpful, but beset by a variety of difficulties. The very vulnerabilities we're hoping to address with these modalities are often compromising a person's capacity to engage with them. So a pharmacological tool that might provide a window into what meditation might be for people, provide some support in accessing meditative states and practicing them, perhaps provide enduring benefit so that meditation training is easier to engage with. These were questions that were very intriguing to me and led me to ketamine. So what is ketamine doing? Overlapping hypotheses have been proposed to account for the antidepressant effect. One is the glutamate hypothesis, that it modulates glutamate in areas of the brain that might be experiencing disequilibrium of glutamate, having too much glutamate, which is the predominant excitatory neurotransmitter in the brain. There's a neurogenesis hypothesis that through BDNF, mTOR, it activates neurogenesis mechanisms, primarily in the prefrontal areas. The functional connectivity hypothesis that ketamine promotes enduring attenuation of hyperconnected areas. Hyperconnectivity is associated with a range of psychiatric disorders ranging from depression to addictions. It's a default mode network hypothesis that ketamine, like other hallucinogens, promotes sustained attenuation of the default mode network, which can have effects on predictive coding, on ruminations, on all of the challenges that might come with psychiatric disorders. So, it's clear from these mechanisms that there's a biological emphasis here. It's understandable given the dominant paradigm of mainstream psychiatry, and also the way that ketamine entered into psychiatry with the work of John Crystal, the editor of Biological Psychiatry. Ketamine was initially viewed as a biological intervention, one that has primarily neural effects that might be leveraged in the way that we might provide ECT or transcranial magnetic stimulation, something that is divorced from any sort of psychological or psychotherapeutic framework. But as we know, ketamine is associated with a variety of psychoactive effects. This figure places ketamine alongside other hallucinogens and entactogens in the case of MDMA. And one can see, ketamine is in orange, that ketamine has effects comparable to those of LSD or psilocybin. One caveat about this figure is that while LSD, psilocybin, and MDMA were assessed in a framework that paid a great deal of attention to readiness for the psychoactive state, for attentiveness to the state, for integration of the psychoactive effects later, ketamine was provided in a setting divorced of those things, bereft of any consideration to set and setting, and that may have had some effect on how the experience unfolded. So as I mentioned, I was interested in providing meditation training to disrupt addiction, and I approached addiction from the perspective of the disorder representing the opposite of what mindfulness might be. Mindfulness is defined as giving deliberate attention in a certain way with acceptance, non-reactivity, moment-to-moment awareness. The term comes from the Vipassana tradition of Buddhism, which is a spiritual practice aimed at achieving liberation from suffering. And it involved not only practices, but certain philosophical milestones that are achieved, recognition of the impermanence of all things, that the self is an illusion, other things that one might associate with the Buddhist cosmology. In secular settings, mindfulness, it has been shorn of those more religious trappings and is now an attentional exercise aimed not at some sort of deep insight or enduring liberation from suffering, but at getting on with life, being able to experience stress, challenging experiences from a place of equanimity. Addiction can be seen as the opposite, as I said, of mindfulness, a compulsive, reactive, contentment-driven process to the detriment of serene, thoughtful decision-making. And non-ordinary experiences might be helpful, given that there may be challenges in accessing these experiences by virtue of the demands of the practice. The practice requires a lot of stillness and attentiveness and commitment. And the reactivity, craving, and ambivalence that characterize addiction may compromise that. So if we were to propose a pharmacological device by which to assist people in accessing these states, might provide an experiential stepping stone. It might lead to an afterglow of enhanced mindfulness, and it may lead to changes in openness, reactivity, and motivation that render meditation easier to practice. Hallucinogens, in particular, might be a helpful device for doing so. So I began doing work with ketamine from this perspective of how we might couple a mindfulness-based framework with infusions. So IV infusions were given in a hallucinogenic dose range. Participants are taught how to meditate prior to infusions. Intention setting prior to infusions is oriented around mindfulness-based commitments, being open, being attentive, non-reactive, and non-judgmental. There may be a particular susceptibility in people with addiction to reifying certain drug-induced experiences and becoming attached to them, wanting to rekindle them in some way. So the mindfulness-related equanimity, dispassion are intended to disrupt that process were it to happen. Participants engage in a body scan for 10 minutes prior to the infusion while wearing an eye mask. And there's minimally guided meditation practice during the infusion. The room is entirely silent. A facilitator is there to be attentive to whether the person needs support. Occasionally will ask the person to take some deep breaths, relax, and will reiterate some of the intentions that come with mindfulness practice. There's a debriefing afterwards. This is a photograph of one of my assistants modeling what it looks like to be receiving an infusion. So we started with some laboratory studies. These were in non-treatment seeking cocaine users. The model that I just mentioned was incorporated into all of these studies, including the clinical studies that will be discussed later. So in a small early study, we found that a single IV dose of ketamine versus a control, lorazepam, improves motivation to stop cocaine in non-treatment seeking dependent people more than 24 hours after an infusion, as well as reduces cue-induced craving. This was a within subject study, meaning everyone got the three conditions, 2 doses of ketamine and the control. And the infusions were separated by enough time so as to sensitively assess their effects. And see here that the dose of ketamine improved motivation assessed by the Eureka scale, reduced cue-induced craving, and drug liking was low for all conditions. What isn't shown here is that a second dose of ketamine didn't have much of an effect on the Eureka score, but it did further lower cue-induced craving. A subsequent study aimed to understand whether these findings translated into behavioral change. So yes, it's all fine and good if participants are saying they're more motivated and if they're experiencing less craving, but does that actually impact behavior? And one way of doing so is to assess whether they choose less cocaine if offered the opportunity in a human laboratory. So we set up a study, received funding for a trial that provided non-treatment seeking cocaine individuals with the higher dose of ketamine from the study versus midazolam, the control, and assessed whether their choice to use cocaine went down 24 hours after each infusion. What we found was that those receiving ketamine infusion were less likely to smoke cocaine. In a paradigm testing the value of cocaine now, we were given 5 choices to smoke cocaine, or money later, money that they would be given at discharge from the hospital. We also found in this trial that reactivity, the propensity to act in ways to adverse or excitatory stimuli in ways that might be regrettable, that went down. Reactivity was dampened by ketamine, but not by midazolam, 24 hours after the infusion. Began this work, as I mentioned, interested in having a real clinical effect, especially in the context of mindfulness training. So in a separate clinical trial, we investigated the question of whether ketamine might promote engagement with a mindfulness-based recovery platform and maintain heightened mindfulness as well as improve abstinence, improve rates of abstinence. Did a clinical trial of 55 cocaine-dependent individuals. They received a ketamine infusion equivalent to the standard antidepressant dose, 0.5 milligrams per kilogram over 40 minutes. And the infusion was given in an inpatient setting. Individuals who were initiating a 5-week regimen of mindfulness-based relapse prevention. Now, in the inpatient setting, they received quite a bit of therapy. We were operating under the assumption that there's a window of opportunity that's created shortly after a ketamine infusion, a few days or so, that may really facilitate engagement with therapy and behavioral change. So the therapy was, mindfulness-based relapse prevention is usually an 8-week regimen. So 3 of those weeks, let's say, were crammed into that first week when they received the infusion. 49% of individuals were abstinent in the ketamine arm versus 11% in the control. During the final 2 weeks of the trial, it's the standard outcome for cocaine trials in NIDA-funded studies. Ketamine subjects were 11 times more likely to be abstinent than the control group. We also found that patients who received ketamine were more likely to stay in treatment and to come regularly to report greater engagement with mindfulness training. There were significant reductions in measures of craving and reactivity. This shows the time to dropout. Ketamine led to longer delay in first use or dropout compared to midazolam. Subsequent study tested this model in alcohol-dependent individuals, incorporated a single ketamine infusion into a platform combining motivational enhancement therapy with the mindfulness components I mentioned in the model earlier. This was an outpatient trial. Patients designated a quit date in the 2nd week, during which they also received an infusion of ketamine or midazolam. You see here that the proportion of individuals remaining abstinent was higher in the ketamine group. And time to first use or dropout was delayed in the ketamine group, as we saw in the cocaine group. So I began by saying the mechanisms are of interest to me, and I was particularly drawn to how the psychoactive effects of ketamine might be impactful. Remember, I had been interested in ketamine because it may simulate the meditative state. I've been meditating a long time, since I was a kid, and always found it helpful at providing calm and serenity and all of those things. But I was also quite drawn to some of the experiential effects, the change in my sense of self and in my relationship to the world, to others, to the mystery of things. And was struck by reports of psychedelics having comparable effects. So that informed my decision to consider ketamine as an adjunct. So this study looked at whether this kind of intuition that ketamine might provide some of these psychoactive effects was correct. And what we find here is the Hood mysticism scale divided into its main components: ineffability, spatio-temporal transcendence, positive affect, revelation of a new reality, or a true reality, and a comparison of the different conditions, lorazepam and the 2 doses of ketamine. What we find is that there's a dose-dependent effect of ketamine on the total Hood mysticism score. And there's also a separation from placebo, or from the control, for both conditions as well. So this had been tested once before by Roland Griffiths. He'd given intramuscular ketamine, compared it to midazolam, but in a setting that didn't involve the meditation component. And he didn't find that ketamine provided any kind of mystical type experience. And that may be because of the route that was used, the intramuscular route, which has marginally less bioavailability. Might be due to the dose, he used lower doses. And it may also be due to the different setting. In a subsequent study, we investigated a wider array of mystical type experiences. We looked at the mystical type experience according to the Hood mysticism scale, and also according to the near-death experience scale. Near-death experience is considered a kind of species of mystical type experiences. Of course, ketamine is a known dissociative. We also looked at dissociative experiences compared to midazolam. Its global improvement scale is a measure of how well people did in the second study I mentioned, the one with cocaine self-administration. So people who reduced their cocaine self-administration, who reported less craving, who had less use in the natural ecology, that all went into the global improvement, and that indicated whether they did well or not. So we looked at whether these different psychoactive effects correlated with global improvement, and they all did. However, mystical type experience was the only variate to remain significant in a full model, in a model that combined all of the different variables. So ketamine, dissociation, near-death experience, Hood mysticism scale. The only one that remained significant was the mystical type experience, which suggests mediation. So this was using the data from the second study. The same finding was found in the first study, the one with ketamine promoting increased motivation, reducing cue-induced craving. But in that study, the mediation only impacted on motivation. So there was a mediating relationship between ketamine, mystical type experience, and motivation, which is an interesting finding. In the alcohol trial, we did a similar analysis. We looked at CAD score, mysticism, and looked at whether at-risk drinking was mediated by mystical type experience or dissociation. We found a similar finding as in the previous two studies with mystical type experience, but not other psychoactive effects, working to mediate the impact of ketamine on at-risk drinking. So these mediation data suggest that engagement of consciousness in a certain way is crucial to ketamine efficacy in diverse addiction treatment settings. And mystical type experience alone is key, not dissociative experience, not near-death experience. One way of understanding this is that the habit-locked, egoistic, agitated mode of engagement, characteristic of addiction, is disrupted in some way, so that fuller consciousness might awaken. Now, the language of that is, I imagine for those of you who have read Eastern philosophy, reminiscent of the way of a deeper consciousness is conceptualized, that there's a fundamental consciousness within that is accessible to all of us that gets obscured by the agitations of thought and various calcified patterns of thinking and behavior. But this conceptualization may also be consistent with neuroimaging data, with psychedelics and meditation, where the default mode network, which was implicated in the organizing schemes by which we understand the world, the ruts into which our thoughts might fall, the mental wandering, the ruminations, the chatterbox, that's attenuated somehow, and creating opportunity for relief from psychiatric distress. So these studies have several limitations. They're not designed to evaluate whether psychoactive effects and therapeutic benefits might stem from a common neural mechanism. So it is possible, as in, attenuated functional connectivity, disrupted predictive bias, or dampened default mode network activity. It is possible that there's a common mechanism accounting for both the psychoactive effects and the benefits that we saw. Expectancy effects might have also contributed to a heightened response. So we did our best in these studies to obscure the binary model, the binary effects of the medicine, it's either midazolam or ketamine. We told people they'd be getting one of several medicines, a range of psychoactive effects. The psychoactive effects are peripheral. Really wanted to be careful about priming people for some kind of psychoactive experience and having them run with that, in deference to the dominant thinking that that a medication effect is somehow independent of some sort of placebo response. But in any case, we wanted to minimize expectancy effects as much as possible, but of course, people are under the impression they might be getting ketamine or psilocybin or something like that. They may be ready for that, and if they feel like they received it, they may experience a sense of greater healing, perhaps. There may also be increased engagement with staff during debriefing, during therapy, following a compelling or inscrutable experience. If there's some sense of communion with a divine being during the infusion, people are going to want to talk about that, and simply talking and engaging more with staff might also be of benefit. So all these limitations notwithstanding, it is important to keep in mind that there's a robust literature of people experiencing these types of things endogenously, spontaneously, and having changes in their lives comparable to the changes that we saw in our participants in these studies, where there's a reappraisal of their values, of why they do what they do, and real change in regards to behavior and the choices they make. So all of these things being the case, it's still important to consider that the experience may be helpful and may on its own provide some disruption in a problematic narrative, an opportunity to rethink one's relationship to the world, to others, to oneself, and to cultivate values that may be healthier and more aligned with well-being. So what about the non-addicted? I think thinking about a mindfulness-based ketamine model relevant to depression, OCD, suicidality, PTSD, the many ways that the mind, body might become agitated, the way fuller consciousness might be obscured. And recent research indicates that a psychological framework, CBT with sensitivity to psychoactive effects, extends the effects of ketamine infusions in depression. In ketamine-assisted psychotherapy, it's being utilized for a variety of psychiatric disorders with anecdotal reports of effectiveness. Ketamine-assisted psychotherapy is much more of a psychedelic model. The model is intended to prepare people for a transformative experience and to use the therapy to help people carry that experience forward into day-to-day life. And the role of non-ordinary experiences in general are being appreciated in a variety of settings, breath work, sound baths, fasting, trance, yoga, sweat lodges. Especially here in the States, there seems to be a kind of revival of practices that historically have been associated with New Age and fringe elements. So addiction is an example of a mind that has been thrown into mindlessness, sort of lost its center in a mindful perspective, and it can lead to great suffering that I think can be helped by ketamine being provided in a context that deepens and extends the capacity for mindfulness. So, in summary, I think there's a lot to learn about hallucinogens more generally. This is an example of work with one member of that family. But as in that early figure, the psychoactive effects are comparable among many of these substances. And it's turning out that neural mechanisms are also quite comparable with neurogenesis, default mode network, attenuation, functional connectivity, attenuation, all having a role in the effects of hallucinogens as diverse as ketamine, psilocybin, salvia divinorum. So I really appreciate the opportunity to talk to you guys. I wanted to just, give some mention of the wonderful collaborators, Carlos Blanco, Richard Fulton, Carl Hart, Francis Levin, Sanjay Matthew, Ned Nunez. as well as the funding that I've received. The data that I presented completed studies, but we have a variety of studies that are ongoing. We have a study building on the cocaine data. It's a large multi-infusion clinical trial that incorporates motivational enhancement therapy, mindfulness-based relapse prevention, provides higher doses of ketamine to individuals who don't respond to the standard dose that we provide. We have a study funded by NIAAA examining ketamine for alcohol use disorders, again, 2 infusions, and investigating closely the synergy that might exist between ketamine and behavioral treatments. It's a 2x2 design with some individuals getting therapy, some not, everyone randomized to ketamine or midazolam. We also have a study investigating the effects of ketamine on opioid use disorder, whether it helps craving, helps withdrawal, whether it can shepherd people through the early, very challenging stages of recovery when the risk of relapse is highest. So I look forward to sharing those data with you when they're available. Again, the staff this is an older picture of my staff, but we had a good time together, and I couldn't have done this work without them and without the participants that have been so grateful and generous with their time.
Great, thank you very much indeed, Elias. That's fantastic sort of overview of a lot of work. Thank you. We'll just head straight into the questions, and in no particular order. Just going to start with one that says, why did you choose the Hood mysticism scale? What are your thoughts on ego dissolution inventory or emotional breakthrough inventory as far as potential correlations to therapeutic effects?
I think those are, fine to look at. I'm going to stop screen sharing here. I chose the Hood mysticism scale primarily because that's what has been used in the field, or that had been used. Other scales currently that are gaining in popularity. There's been research, psilocybin, using the Hood mysticism scale. A lot of that research is what motivated what I did here. But I think the emotional release component of a ketamine experience can be very helpful. I think abreaction for certain disorders is an important therapeutic process. Similarly, ego dissolution, as many of you may know, the Hood mysticism scale does have queries that target that experience specifically. You feel as if you've been integrated into a whole larger than yourself, or that you've disappeared into some great void. There are questions, and one can more sensitively look at particular items and understand what might be most impactful. Future research. Should mention that one very interesting finding from the mediation analysis of the alcohol data is that ineffability, the impossibility of articulating something, of putting it into words, correlated most highly with improvement, which is interesting and gets at maybe a more fundamental. I personally consider the ineffability of the experience as more captures more intensely what is sacred about the experience, if we want to use that language, than ego dissolution. Ego dissolution can happen with deliriums, for example. There may not be one whit of sanctity about it, just sheer horror and discomfort. But having an experience where one is poised in kind of ecstatic admiration of something that can't be possibly articulated beyond understanding, I think captures more fully what the sacred or the mystical might be.
Thank you. A second question on this just issue of measurement. Why do you think some trials find relationships between the Hood mysticism scale but not the CAD score and treatment outcome? And I guess that's sort of just speaking to the topic of your talk, really. I suppose it's asking the question why.
Yeah, well, I think what we're seeing here is that a particular subset of effects is most impactful, as opposed to a more general marker of psychoactive potency.
Okay. Thank you. Were there any ketamine-assisted psychotherapy type integration sessions post the infusion? So this is a methodological question.
Yeah. So for the laboratory studies, there was no psychotherapeutic or behavioral framework. These were non-treatment seeking people. All they received were infusions, and then the debriefing afterwards, which is intended to ensure that they came back to earth in a healthy manner. But there was no, what did this reveal about your relationship to drugs, or how do you hope to move forward? None of that. With the other studies, there was invariably engagement around the contents of the infusion. And people would bring up that I felt really peaceful. I realized that that's my true self. I'd like to continue cultivating that peace, finding room for it. For example, I was reminded of all of the violence I've done to myself and to others, and I want to be free of that violence. And using those sorts of sentiments as starting points for more sustained conversations about how they might change their values, their behavior.
So was there a structure to those sessions after the infusions? So was there a sort of formal number of sessions or time set aside for it?
It varied depending on the study. The cocaine study I discussed was a strictly mindfulness-based platform. So the conversations invariably were refracted through that perspective. If people are talking about peace or equanimity, we bring it back to how that might be relevant in mindfulness. With the alcohol study, there was greater room for a more tailored approach to the contents of the experience. It's an MET, motivational enhancement therapy platform, and motivational enhancement therapy is very much patient or client-centered. So the person, in a way, designates the language by which we approach the problem. And the infusion may lead to a certain vocabulary, a certain set of attitudes or goals, irrespective of mindfulness training, that we might then continue going over and evaluating and discussing.
Thank you. I think what we're going to do is we're going to change the normal format because we've now got 10 questions here. Then we've got quite a lot more questions. So if it's okay, should we just go through these? Somebody's asking, what fraction of the total dose do you give as a bolus?
I give 0.11 milligram per kilogram over 2 minutes for the bolus dose. The reason for that dose, there were some early data I didn't discuss of looking at ketamine levels through the infusion, and we wanted to, in a way, jumpstart the infusion as early as possible, rather, for infusions that are strictly drip over 40 minutes or so. It has a slow come up, and we wanted to get people into a kind of therapeutic dose range or therapeutic serum range as early in the infusion as possible. And we found 0.11 milligram per kilogram to be adequate at doing that.
Okay. Another dose-related question. Not sure if you presented this data, but do you think that the dose has a linear relationship with mystical experience in the dose ranges you used from 0.41 to 1.41 milligrams per kilogram? So
yeah, that's an interesting question. In the one of the figures, I showed a dose-dependent relationship, at least between 0.4 and 0.7. I haven't yet looked at whether the experience continues growing more mystical with higher doses beyond 0.7. So I can't really comment on that, but from clinical and anecdotal data, it does seem that it varies with the person, and sometimes one has to push a higher dose in order to achieve that kind of experience. And at the same time, I encourage caution about that. I think we should be very careful about chasing a certain experience or seeing it as a holy grail of transformative experience. So I can't comment on whether higher doses are indeed associated with more mysticism. Something to investigate further.
A sort of question that's been asked is about the drug. Obviously, you're focusing on ketamine, but can you comment on similarity or differences from other drugs of abuse, and in particular DMT? Would that be superior in the treatment of addictions?
That's an interesting question, and one that I'm actually considering testing. Proposal to look at IV DMT. So DMT is a serotonergic hallucinogen, often associated with quite intense visual imagery, a similar kind of transportive quality. Often people describe entering into a different world, being unmoored from this one, in a world that's entirely kind of self-contained and independent. It doesn't seem to have the same impact on speech and thought that ketamine does. Ketamine can be quite disruptive of those things. initially it was tested to mimic the negative symptoms of schizophrenia. Those who are familiar with ketamine's effects can see how disorienting and it can be in that regard. So, yeah, my central hypothesis has been if we can get medicines that, simulate these experiences associated with like a bona fide meditative state as fully as possible with minimal impairing effects, the better. I think that's so. If DMT might be able to do that, then great. DMT may have its own challenges in terms of providing such a sui generis experience where they're like communing with aliens and self-dribbling basketballs, as Terence McKenna called it. I'm not sure if that lends itself to the sort of existential reappraisal and capacity for mindfulness that I'm hoping to cultivate with these medicines.
So from your experience of doing this, Elias, do you can you say anything about the longer term effects in your studies on patients? I mean, I don't know whether you have active follow-up for them, but perhaps just anecdotally, whether you can say anything about that.
We have 6-month follow-up for all the studies I mentioned, all of the clinical studies, that is. And yeah, there seems to be a persistent effect. I think something like 40% of people in the ketamine arm were abstinent in 6 months, and the preponderance of people in the ketamine arm in the alcohol study were also abstinent.
And do you think that the people who signed up for this study have already had a particular orientation towards mindfulness?
No, these studies were advertised as part of a kind of larger collective of adverts in the division for substance use clinical trials, and so it was basically, we're doing medicine trials for cocaine use disorder, alcohol use disorder, opioid use disorder, cannabis use disorder. Call if you want free confidential treatment, that kind of thing. So we didn't have we weren't heavy-handed at all about it. That may change with these more recent trials. We as I've been kind of setting off on my own and advertising entirely for my studies, there has been more mention of, we do incorporate mind-body practices. But yeah, in the early studies, not at all. And in some cases, it may have been something we had to kind of cajole people into doing. They may have certain problematic associations with meditation, having tried it in recovery and found it hogwash or something. Yeah.
Would you have any advice for clinicians who are using ketamine but not using a mindfulness or psychotherapeutic orientation? Say they're just using Spravato, for example, or something like that, as to sort of a simple way to get started in using and developing a sort of mindfulness adjunct to their practice?
Yeah, well, I think it's unfeasible to expect people to provide the kind of robust therapy platform that some of these studies do. But in the service of improving the tolerability of these medicines, mindfulness can be very helpful, if only providing some brief training in how to sit with one's thoughts, how to roll with whatever's coming, ketamine, as you all know, can sometimes be distressing and can lead to unusual and challenging experiences. And providing people with some practice for navigating those waters if they become too turbulent and challenging can be helpful. So that's one way I think of incorporating mindfulness into it, short of just getting into MBSR and BRP with them. And I think it's also a very efficient way of integrating to suggest to individuals to tap into whatever that experience might have been by having some breathing exercises they do on a daily basis, of recapturing any serenity or lightness or freedom from their thoughts that they might have experienced during the infusion or immediately afterwards. So that's a way of imparting some mindfulness to the clinical relationship without perhaps diverting too many resources.